I will go through a little bit about why we're talking about this topic today and my connection with it. So today our topic is going to be digital connection, ethical engagement, and youth telehealth. 10 years ago, this probably would not have even been a topic that we're covering because we're going to talk about how the pandemic forced us to really reevaluate how we work with youth and adolescents and their parents in the telehealth space. So let me go ahead and jump in. These are the three bullets of what I'm hoping to cover and what you'll take away today, right? We're going to talk about fit. So who is an appropriate candidate for telehealth? Oftentimes, like parents might think their kids are like, it's easier for the kiddo to go and be online and do their session. It works for some children and youth. It does not work for other kids. So we're going to talk today about who would be a good fit and who would not be a good fit. And I will just say this, sometimes it's not a good fit and that's okay. They'd be better served by someone in person. And we'll talk about that. We're going to talk about ethical practice. So whatever mental health organization that you fall under, whether it be social work or counseling or LMFT, there are practical ethical guidelines that we have to follow, specifically in the virtual setting, because we lose a little bit of that connection when we are not in the room with someone. And then I'm going to go over some strategies of ways you can engage your children and youth when you're connecting the way we are right now behind a screen. So that's kind of our big things today. I know it's a lot to cover. So like I said, I'm going to try to get through it not as quickly as possible because I want to make sure that we go deep into it, but I do want to make sure we cover everything. Okay, so I'm going to set the stage here, right? It seems like it maybe was just yesterday, but about 6 years ago, we had this huge shift, right? Like everyone knows that we lived through a global pandemic and we're on the other side of it. That's where this shift in virtual care came. Fun fact, the kiddos that did kindergarten in via Zoom are now going to middle school. So the kindergartners that did Zoom school are now going to middle school. So their whole elementary years are complete. I have kids tell me that they're like, when I'm doing an intake and they're like, tell me about school, where'd you go? And they're like, kindergarten or first grade or even pre-K was online. So that is just something to preface as we work through this today. So COVID forced us to normalize virtual learning. Many of you may have parented through virtual learning, virtual school, and had to help your children through that. Not only did school for our young people go online, healthcare did, right? A lot of people were moving much more towards virtual visits, unless it was an emergency or something that went to a higher level of need. Okay. Also, how many of you use FaceTime, Zoom, connecting via or even remote work more than you did 6 years ago? I bet you it's 100% of people here, right? It's just so much easier now because we are more equipped and we're more comfortable to use it. So now youth are coming to us being able to understand how to use technology, but they're also fatigued because I don't know how many of you are parents yourself, they're on screens constantly at school. I have some kids that tell me they're even in school on their screens more than 60% of the day. So by the time they might get to us after school, they are screen fatigued. We are probably screen fatigued too if you work fully virtually. So I say this because there are guidelines for ethical telehealth practice, but they sometimes are still not up to date with where we are technically, okay? So my first question, I'm going to do some question check-ins throughout, is how many of you work with kids and virtually? And what is the hardest part about this? Go ahead in the chat. It says share with your neighbor. This is our virtual neighbors. What's the hardest part about working with kids and youth, so anyone under 18 virtually? And I'll just read out some. Engagement, attention span, confidentiality, yes. We're going to talk about these things. Rapport, distractions, competing attentions, right? Bonnie and I were just talking. that they try to kind of fool us, right? I had a client that was wearing glasses and I could see they were playing a game through the reflection in their glasses. And I said, I can tell you're playing Roblox right now. And they're like, no, you can. I'm like, I can see the reflection in your eyeglasses. So like, and I think we are programmed since the pandemic to be multitasking, right? Like several of you might be doing several things right now. That's just kind of the way that where things are right now. Okay. So yes, a lot of what I see in the chat is we have a lot of commonalities here about what is hard about virtual work with kids. So we're going to talk about how do we problem solve that? What do we do with that? Yeah, harder to moderate. Parent involvement can go both ways. Sometimes parents are very involved and helpful. Other times the kids are responsible for getting set up on the devices themselves and they can't troubleshoot. So there's still some technical barriers too that we see. Okay. So what are some common challenges that we see? Increasing distractions at home. I often hear background conversations. Maybe they're not in a very private space. The dog is running through. They're trying to. If I see teenagers, sometimes they're cooking a meal. They're doing 7 things at once, right? So increasing distractions, screen fatigue, and that is real. We as adults also experience screen fatigue too. This I'm very curious. Give a thumbs up or a reaction if you agree with this. How many of you are finding sometimes parents and even kids themselves, the virtual session can feel less serious to them, or they're not taking it as seriously? That has happened to me many, many, many times. Or they think because they're not in the room with me, they can get away with more, right? Of being distracted, not those types of things. So I think that's a big one, is like the not feeling less serious. Joining from inconsistent locations, a car, a bed, a kitchen, shared space. In the chat, what is the oddest place someone has tried to join a session from? Grocery store, Walmart, the bathroom. Yep. I'm like, please take care of your business and then you can come back here. Picnic table, car, hotel, right? Like we're seeing all these really odd things. And these are conversations that we need to have, like, are you in a private space? And that's where I think the feeling less serious comes in, because they're not coming into a physical space. So they think wherever they are, they can take the call. Okay. Limited privacy. If they're in a public space, they're going to have limited privacy. Multitasking. So looking at other tabs, playing games, videos, chatting, difficulty sustaining attention. Here's where you can tell they're on their phone off to the side. Or they have 6 tabs up and they're kind of not engaged. This is another one with telehealth. Harder to read body language and those subtle emotional cues. We can only see them oftentimes from the shoulders up, so we can't view some of those things. Like we sometimes don't even know what's in their hands, right? Like maybe they're fidgeting, or maybe they're wringing their hands, or maybe they're doing things that we'd be able to pick up on in the session, and we're not able to see that because of the limitations. And then less access to ideal therapy materials. I work with kids. I'm a play therapist. So I didn't give a little bit of my background just for sake of time, but I've worked with kids for 15 plus years. And I'm very play-based. So yes, they have toys and they have materials at home, but we don't have the bouncy ball, the yoga ball, right? They don't have, in my office, they can freely walk around, right? Like they can walk around, we can move. So there are some limitations there. Okay, what are some other challenges that we have? Connection, right? Even here today now, we might have some connection issues, right? Where it's like, please go out and come back, and Zoom can just be finicky sometimes. It's harder to co-regulate with someone behind the screen, right? Like where you can pick up on those body cues in a session, it's really difficult to do when you're behind the screen, because we are not physical. I feel that when we're in the room together, we are picking up on that body language. We're not able to do that as well behind the screen. Reduce therapeutic connection or presence. And I say this on both ends. We've talked about the youth, sometimes maybe not taking it or not being fully engaged. But I notice sometimes I have to really check myself about being present, right? So like, what are our own parameters around like putting do not disturb on our phone? telling if you're working, how many of you work remotely or do telehealth sessions? It's probably a very large handful of us. Yeah. So that was a change, right? We have to set up our own parameters of how we are engaging, how we're not get distracting, right? If you have people at home, right? I have a toddler. I have to make sure that I'm not taking sessions when she's home because she's very loud. Even if she's not in the room, I can hear her, talking and running and those types of things. It's hard. Caregiver involvement can be inconsistent, right? Sometimes, like we said, they can be very hands off, and other times they're like so involved. They're trying to listen, and there's not that privacy piece. And then avoidance behaviors are easier to mask virtually, right? Like, because there can be a variety of reasons why they're avoiding, or they're we would be able maybe to determine that they're avoiding a topic in session based on body language, and we're not able to see that as much in the virtual space. So those are some of the barriers, pretty much all the ones that you all have even touched on as well. So who is and isn't a good fit? I will say that not everyone is a good fit for telehealth. We'll talk about equity, we'll talk about access, and like there's some cases where they're not a good fit, but it's better than having no access at all. But there are cases where the child could come in to do a virtual session, and that would be more appropriate than virtually. Okay. So who is generally a good fit? Also, it's not a one size fits all. So, and it's a lot of on us too of what clinically we feel is appropriate. I know some people that will take young children virtually. Obviously, the parent would need to be involved. I have a very hard time engaging. The youngest I can probably actively engage is maybe 8 years old. I've done younger. It was not the best, but that was during COVID. We had to do what we had to do. So who's often a good fit? Youth in rural or underserved areas who would not have access. So we're talking people that their choice is either no access or access via telehealth, right? That's a very good positive about being able to provide telehealth services. Families without reliable transportation. So if it's going to be such a burden to get them to the therapy office or the agency, that would be someone that's a good fit. Students who need continuity between in-person visits. What does this mean? Hybrid model, right? Maybe for example, I have a client that's on vacation this week up north in Michigan. What did we do? They really wanted to have their consistency, so we did a virtual session. This is the very first time we did virtual. We don't really do virtual. It's a teenager. We did it. Continuity. Teens who are comfortable with technology and verbal communication. So we're talking teens that can appropriately use technology and are really responsible to use it would be a good one. And then mild, moderate anxiety, mood, or behavioral support. I would argue for children 18 and below, if they have very, very intense crisis, high needs, telehealth once a week is probably not going to be a good fit for them, right? They need a higher level of care. Yeah, someone said telehealth's a good way to start if like the in-person, especially with kids, like where I'm at, where there's a lot of access to providers, though there's always a wait list to see kids. Like they'll be like, the university hospital, I'm trying to get in for behavioral health, and they told me it's 9 to 11 months, right? So sometimes virtual can be that bridge before they're able to get in person. So who might need hybrid or fully in person? Active safety concerns or high risk behaviors. This is everyone's gonna have their own personal preference, but if someone for me has self-harming behaviors, suicidal ideations with plan, I'm going to suggest that they have a higher level of care than virtual. Some other people might feel differently. That's just personally what works. That's just personally my own way of seeing things in my own capacity. Unable to actively engage. I've had some parents are like, I would like to start therapy for my 4-year-old virtually. I'm like, okay, let's talk about this. It's probably not appropriate for your 4-year-old to be on the screen doing therapy for me. Okay. So if they also don't ever have access to a safer private space, and they have suggested, I've had some clients say my mom listens in, or my sister's listening in. I really would like to come in person so I can have the privacy. That might be a discussion that we had. young children needing play-based or sensory intervention, right? What do I mean by that? Like the ability to move around, the ability to touch tangible things in the office, the need to do dance or movement or art. They would probably be best served in an in-person setting. Someone said, can you see people that are outside the state? At least with social work, unless you're licensed in the state, you cannot see someone outside of the state, right? Like if someone was in Ohio, I can't see them. I'm not licensed in Ohio. So check that. That is profession to profession, state by state. So make sure you are always, and that's why it's important to verify where they are, right? I'm not licensed in Florida. I had a client try to join from Disney World. I'm like, I can see you're at Disney right now, right there at the resort. I'm like, I'm not licensed in the state. We're gonna have to reschedule till you get back. So you always want to verify that too. You'll get some really interesting things that you see when people are trying to do telehealth. Yes, there's also legislation for the social work compact. For those that are social workers, keep an eye out from that. It's in the works right now, but it's not law yet. Okay. Telehealth is not less than. I want to say that. Some people are not a great fit. Some people, I have better sessions with them online than I had ever in person. Okay, so it's not less than, it's different, and we need to be flexible and creative in how we're going to engage. Okay. Why does telehealth matter for access? So now we're going to talk about how do people access services, and you can, brainstorm all the different barriers that would be a barrier for someone to come to services. Okay. The purpose of telehealth should be to reduce burden and improve access to care. And I would actually argue quality care. Okay. So we want to lower logistical barriers. We talked about that, transportation, cost. If someone's using public transportation and they can't afford it, scheduling, childcare, geographic distance. I've had some families that work very odd hours, right? So they maybe have a parent on nights, so they can't, or the parent is working during hours that I offer services. So that would be an example of logistic barrier too. It should be considered as an option so families can connect more consistently. Okay. It reduces barriers. Geography, we talked about that. Think of places where someone is very, very far from a provider. And it does not make any logistical sense for someone to be driving their child an hour and a half each way to get therapy, right? That is an undue burden. That would be an example. Transportation. So I can't miss work. I don't have anyone to take them. I don't have money. Or it's a burden, or it's too expensive. I mean, gas price, that is very, very, very real, and our families are struggling right now. Okay. And then scheduling. So working around parent work schedule, school days, siblings, childcare logistics, right? Especially I'm thinking families that have multiple children, none are of driving age, and they're like, I can't put all three of my other children in the car to get the one child there. It's just logistically too challenging. Okay. These are just examples. So in the chat, what are some barriers you have seen as to why a family or you suggest virtual care? We talked about, some of those main ones, but there might be other things that I'm overlooking as well. What are some barriers? Yep, geography is always one. Surgeries, like medical stuff, right? Like there are some, I actually have had some clients where the parent is going through, maybe the parent had surgery or the parent has a chronic illness and they can't get them there. Oh, long interruptions in therapy, phone or internet cut off. Yeah. Anxiety leaving the home. I think that's a big one, right? You might need to start virtually to build up the skills because they're not able to yet access leaving the home. That's a really good one. More virtual. I'm so glad someone brought this up. Someone said that the reality is in some areas, there's more virtual providers than in-person providers. What if there's a provider that's a good match, but they don't offer in-person, right? So, I mean, in a perfect world, everyone would get the access that they need, but that doesn't exist. Okay. So these are things to think about in whatever way you engage. I know we have some private practice owners. I know that we also have people in community mental health or agencies or schools. So sometimes our location also is parameters that we have to work around. Okay. Why is telehealth helpful for continuity of care? Say a client is in and out of the hospital. To be discharged, they have to be set up with some level of care, right? Maybe the fastest way they can connect with care outside of the hospital is to do virtual, right? And so sometimes transitions in and out of hospitalization from inpatient down to a step down, the best until they can get in-person care is virtually. Okay. Being able to meet virtually is sometimes better if you have a relationship with the person than not having care at all, right? College students, right? Maybe you're in the state that the college student is going away to and they want to continue care and they want to see you virtually. They may be used to see you in person. I have a couple clients like that too, that they've gone away different parts of the state and now I see them virtually. And they can come back in person if they want. What I see is when teens go off to college, they often like get into a routine of in-person, of virtual, and then they start to like it. But sometimes then when they come home for breaks or summer, they can see me in person. Illness, school breaks, or seasonal disruptions. This is where I want to say set boundaries. You don't want a kid that has a fever and slumped over coming on for a session just for the sake of coming on a session, right? So it can be good though if it's like something that maybe it's a cold and they don't want to get you sick. You don't want them to get sick either, where they can do it virtually. Or I've had some clients like, I have a really, really bad migraine. I don't want to drive in today, right? So is it okay if we do it virtually? Or parents. Sometimes they're like, my kid is completely fine, but I'm sick. I can't get them there. So can we do a virtual session? Snow days, right? Like sometimes they're like I live in Michigan. They're sometimes like the weather's way too bad. I can't get them there today, right? My street hasn't been plowed. Can we hop on virtually? I would say though, try to have policies in place beforehand so that you're not like 5 minutes before scrambling. That is a big mental switch to go from expecting someone in person to then having to hop on virtually. Okay. So telehealth has been expanded. Obviously, a lot more of us are on it, but it's not equal. There's still an access gap. So lower income and publicly insured youth need virtual access the most, but they access it less than their counterparts. Youth in rural communities need the access to virtual care, also don't access it at the same rate. And then Black youth, even when their clinical need is comparable, are using virtual sessions less. So it's not inherently equitable, right? And I will say there's probably many systemic barriers that make this difficult for these specific vulnerable populations. So that's just something to think about. Yes, we kind of take for granted, I think, that having technology is a privilege, but not everyone has internet access at home. It's definitely more accessible, but it's not free to have internet, right? So we have to think about those barriers as well. Okay, so in the chat, I just want you to think about this. So here's our little reflection. The youth who most need telehealth are the least able to access it. What would you as a provider, so this is going to be different because I want you to think of the area that you work in. What would you need to do to reach the most, those clients that I talked about that need telehealth the most? So think about where you are from. What would you as the practitioner need to think about or need to do to reach those hard to reach clients? And you got to be creative here sometimes. So what are some ideas that you might have? Yes, meeting during the school day. I think that's a really, really good one. It depends on the school, but a lot of schools I've also said, can they have a private room for 30 minutes once a week? Being flexible, right? Within your own boundaries. I'm not saying work all hours of the day, right? Finding ways for them to have internet access. Absolutely. Connecting them with the school or a case manager or working with the supports that they have, meeting at a library maybe, right? Or having them set up at the library. Libraries, oftentimes you can rent computers if they don't have one. Yeah, these are really great. You can go in the chat and look at them, but partnerships with community resources I think are great. Also, I would say be flexible. I prefer, obviously, a client is signing on from their computer, but if they have to sign on from a cell phone, they have to sign on from a cell phone, right? Like we would talk about these things before, yes. So sometimes we have to be flexible. But these are really good things that I just want you to think about because we have to get creative sometimes, right? We absolutely have to get creative sometimes. And I would say some schools are like, no, learning time's learning time. I worked in a school for many, many years. If a parent reached out and said, hey, like my child needs some outside support, I would go to bat and advocate for that student to have access to a private room. Doesn't mean that the admin would allow that, but I, as the school mental health professional, would definitely advocate for that. Sometimes it's advocating. Okay. Let's keep going. Now we're into the ethical and clinical part. Okay. This is not going to be the most exciting. Ethics is usually not, but why do ethics exist? To protect our clients and to protect us as the providers. Okay. And I will preface this by saying I am a social worker, but whatever professional body you belong to, you have a code of ethics and you should follow that. So if I'm referencing the NASW, they are very, very, very similar, but the language may vary based on your profession. Okay. So what do we need to consider ethically and clinically? Confidentiality and privacy, huge, right? Technology, like we said, some people are calling from like public areas, right? We can't guarantee confidentiality that way, right? These are discussions that we would need to have. So there's environmental factors to consider, technology factors to consider, and then systematic considerations for confidentiality that we're going to walk through. Okay. What is the first bucket? We're going to talk about environmental factors, okay? Where they physically are, where are you seeing this client and where you physically are. You should absolutely have privacy too. You should not have people ever hearing what is going on, right? That's a violation. So vulnerable groups are ones we have to really think about. What if someone has housing instability, right? That's going to be quite difficult. Maybe they are in a shelter or they're in temporary housing. So how do we ensure that they can at least have some sort of privacy while given where they are at, right? They might not have a super private space. I'm sure many of you have gotten creative too. I've had some people that are like, can I put my child in like the bathroom with the door closed? I'm like, if it's going to give them privacy, fine, right? Like headphones are definitely like a good one too, right? I'm going to put my headphones in so not everyone is hearing. Biggest pet peeve is when people are like on speakerphone in a public space, not doing therapy, just in general, when people are on speakerphone in a public space. Some people are in households where there's many, many, many people, right? They don't have their own room. So we have to be creative here. I've had some kids that are like, their parents sets them up, weather permitting, outside. And everyone will come inside and give them privacy that way. Bathrooms, absolutely. Closets, right? Sometimes like we just have to be really, really mindful. Someone said, can my kid go in the garage? It was a teenager, right? Sure, if that's going to be like the best place that they can access. Some people are giving really good options too for the technology piece. So we're going to get to that in a second. Environmental best practices: check the suitability of their location before and during the visit. What I mean by this is do the best that you can to ensure privacy. These are those conversations you need to have where they're calling from a bus, they're calling from the car, and we're like, this doesn't seem like a good time. We're not going to be able to like connect today. Let's reschedule. Right? So these are things to think about when you're getting calls and they're signing on from like all different sorts of places. Technology. Data, security, exposures. You probably hear about this all the time, like, right? This doesn't happen as much, but like, do you remember at the beginning of using Zoom and random people would show up in your meeting room and you're like, what is going on? This before we had like waiting rooms and password protections. So you want to make sure. I always have people go into the wait room. I've had times where it's password protected to get into the Zoom room. Or whatever EHR you use that is compliant. You should be using something that is compliant and protects HIPAA and confidentiality. So best practice could be platform. You have to use a secure platform. So you might use actually the technology in your telehealth portal. I use Sessions Health in my private practice. They have their own portal, but I use a HIPAA compliant Zoom for my clients. If possible, you want to have them avoid public Wi-Fi, right? Because there could be issues with accessing the Wi-Fi. If they're sharing devices, what could be some problems with sharing devices? I've had sometimes parents like go being able to access the chat and see what they were talking about afterwards. That privacy was compromised because they were on the parent's computer. So also you might want to troubleshoot those that might be low literacy and maybe need support there, and those that might just not be super tech savvy. I include young people. They are on technology a lot, but they oftentimes don't developmentally understand the risks that are involved, right? They're like giving out their location, they're, sharing and this and that and the next thing. And I'm like, let's have a discussion about what is appropriate technology used in that, right? And a lot of times they don't know when they're like, there's a lot of things on our phones that can track our location and different things. And if we are like sometimes confused on it, the children definitely are not really tuned into it. Okay. I've had some clients say, can my friend join the session today? I'm like, no, I don't have consent to see your friend. Right. So you have to think of that too, like who is trying to come in the session? Who do you have consent to see? Those type of things. They're like, but I really want my friend to come in. And I'm like, no, your friend wouldn't come into the office and do that. So no, your friend cannot be on the session. And then systematically, you should definitely know what your agency, your private practice policies are. You have to have confidentiality and telehealth, HIPAA protections in place. I personally, I'm in private practice. I have all of my clients sign a separate telehealth consent saying, if we ever do telehealth, here are what you need to know, and you're giving me consent to do telehealth that way. So I have a completely separate telehealth in addition to my informed consent. That's like double protection. I just do that because I never want to get into a place where they're like, I never consented to do something via telehealth. You want to always make sure that you are protecting yourself and you're practicing your license. So you want to make sure you have privacy policies. So all the stuff we're talking about, please try to be in a private space, you have protections. All of these things should be talked about in the intake session with your clients as well. Okay. If you are in a position where you supervise, make sure your staff are aware. I think a lot of times we have been, for like at least the past 5-6 years, so reliant on Zoom and technology. We assume everyone, kind of understands the ins and outs, but sometimes we need a refresher, and we need a refresher to our staff. We need a refresher for ourselves. Verify patient identity each visit. Where are you calling from today? Like sometimes the kid will sign on and I'm like, okay, if we get disconnected, here's our plan, right? We'll try to sign back on. If that doesn't work, we always can back up to telephone, right? But you want to have that in place so that, say, the internet cuts out or their connection cuts out, you're able to still connect. Informed consent and boundaries. We talked about this throughout what I was just speaking about. So I'm not going to go too deep into this, but you need to know what confidentiality is and isn't for telehealth. I can ensure confidentiality and privacy on my end, but if they're at home and people are listening, I cannot, it's similar to group work, right? I cannot guarantee that there's the space that they're in is completely private. Set clear boundaries about messaging, off hours contact, and platforms. What is appropriate? What is not appropriate? Even if you respond to emails at certain times, so maybe I have a toddler. Sometimes later at night, I'm responding to emails, but I don't want them to think that any time of the day I'm responding to emails. I will respond within 24 hours, or I will respond within 48 hours. If you are in crisis, please, here's the resources that you should access. And then revisit consent as the use situation or platform changes. So if you do have to pivot to going to virtual, make sure you have that telehealth consent on file. Okay. Safety planning. How many of you have had to safety plan with someone virtually? Yes, I've had to do it as well myself. It's a little bit different when you're doing it virtually than what you'd be doing in person. If a child, a youth, a minor goes into crisis while you are in session with them, it's not the same as if they are in your office, right? I can't physically intervene. I'm not physically there with them. So things that you would rely on, you can't rely on. You might not know where they are. So say they are in the state that you practice, but like they're at an aunt's house. How if I needed to call 911, I wouldn't know the whereabouts of that person. So you need to know like where they're from, or like who would be the emergency contact. Okay, you can't physically step in. Similarly, like if you were in a school, I can call for someone, hey, I need backup. If you are in a setting with multiple workers, you have a team that might be able to jump in to help you. Or when I've been working in the office, sometimes the parents just right out in the waiting room, I can go get the parent. It's different when you're safety planning virtually. So it's harder to read the warning signs, body language, restlessness, and other cues. Or what if they just turn their camera off randomly and it goes silent, right? Like you need to have plans of what will happen in a crisis when doing telehealth with someone before it happens, right? You don't want to get into a situation where they drop off and you don't know what happened and you don't know who to contact, right? So you want to make sure that you have a plan and you go through this with the youth and the parent before you even start telehealth. What is our professional responsibility to ethically practice telehealth, right? You must, this is within all of the code of ethics, right? You have to use HIPAA compliant platforms and document accordingly. I'm sure many of you bill insurance. There are modifiers we have to put when we're billing insurance to say that they were virtual or not virtual. If I have a client that's refusing to turn on the camera, that has happened to me a couple times, I will note that. Client declined after several invitations to turn on camera to be on camera, right? So anything that you're noticing in the telehealth session, please document. Why do you think it's important that I put in that note that I've invited the client to be on camera and they declined? Why do you think in a note that'd be important? What if something were to happen, right? Liability. And I didn't see something, like what if they were self-harming during that time and I didn't know because they weren't on camera, right? I would say in my notes, I invited them, I could not physically see, right? Safety concerns, absolutely. Everyone here is from different states. So know your state's laws and licensing rules for cross-border care. We talked about that. Don't assume you can ever practice in a state that's not the state you're licensed in. Like I said, there's a compact in the works for social work. I don't know about counseling and LMFTs. And I know there's a SIPAC for psychologists, but it's different for profession and it's actually different state by state. So know which your laws are for licensing. You could be in big trouble if you took a session with a client and you are not licensed in the state that they were in. If the client lies about their location, we can't help that, right? I know that some clients have not been forthcoming with me, right? But I just, in the notes say client said that they are in the state of Michigan, right? We can't verify. We do the best that we can. Stay current with evolving guidance from your licensing board, right? That's with ethics and that's with professional guidelines. We always need to stay up to date with that. Technology is evolving. And I think especially, this is not in my slides, but I think it's important. There is a lot of AI assisted technology coming out, especially for note taking and private practice management and all these different things. If you are using AI, I definitely suggest you're getting consent from your clients to use that. My EHR has an AI tool. I have not. I have a small practice, so I don't need it, but I have not opted into that. However, I've taken my daughter to the doctor and her doctor said, I'm using this new AI note taker. Do I have consent to use it? Right. So if you are using an AI tool, make sure you get consent because that's a liability and a safety risk too. And a lot of these AI tools are not created by mental health professionals. They're created by tech people. So you want to make sure that privacy is secure. HIPAA is upheld, all of those things. Okay. That's the professional responsibilities. Okay, the last little bit we're going to focus on for the last little chunk of time we have together is how do you connect with someone behind a screen? How do you build real connection? And I would argue there are some clients that I have very strong virtual connections with and other that I can tell that there's just a little bit of a barrier there. So, but how do we build connections with our clients, our young clients? Relationship first. The technology is the medium, right? The technology is not the intervention. It's the way we're connecting with them. So we're going to talk about 3 connection building principles you need to think of. So rapport. If you don't have rapport, this doesn't matter if you're in person or virtually. If you don't have rapport, it's not going to be a strong therapeutic connection, right? So you need to lead with that rapport. It just might take a little bit longer if you are in telehealth to build that. Or there are some people that right away, like they feel more comfortable in their home, right? So they're like, let me show you this in my room and that. And the next thing, and they feel so comfortable that we're able to build rapport because they're able to feel more secure in their home settings. Age attuned. You have to consider the developmental appropriateness of what you're doing with your clients. What you would do with a 7-year-old is probably different than what you would do with a 12-year-old and probably very different than what you would do with a 16-year-old. Okay. Oh, someone said when you say get consent, if you're using AI, like if you're using AI to come up with, if you're using AI to come up with a strategy or an intervention, do you need consent for that? No, I'm talking about if it is within like the way you're taking notes or it's recording them or it has, or the AI has access to their health record. Does that make sense? Some of these AI things do take access of your records, of your health record. Or if you guys, I don't know how many of you use Zoom, but there's that AI transcript thing. I always turn that off. I don't need the notes because I don't need them, right? But maybe some clinicians would have note taking on, right? Also, or sometimes note taking might need to be on for a client that has accessibility issues. So maybe they need to go back and look at the notes because they have some sort of processing challenge or something like that. And then the last piece for connection building is collaboration and choice. Yes, they are virtual, but we still want to give them options. They're creating the space together. We want to help them decide, do you want to start with a check-in or do you want to start with a quick game? I have a client that we always start the session with Wordle. Whatever the Wordle is of the day, that's how we're starting the session. And that's kind of a nice transition into the session for us. So those are things to think about. Okay. What are some ways you can work with young children, right? Like what are some ways you can adapt? Use screen tools. So there's like the whiteboard. Make sure they're using it appropriately. Sometimes they're drawing like devil horns on me, right? Like make sure they're using the screen tools appropriately. Maybe you're sharing a YouTube video. I've had some clients we build a playlist together. Shorter sessions, shorter check-ins. Sometimes I've had clients that really by the 45-minute mark, pretty much by the 30-minute mark, we've lost attention. These are sometimes maybe a child has ADHD or they're younger. So we've changed it. We meet for 30 minutes now. I'd rather have a very solid 30-minute session than I would a 45-minute session where they're checked out for 15 minutes. Or maybe you need to check in more frequently. Maybe we're going to do 2 30-minute sessions a week instead of 1 60-minute session. Of course, sometimes insurance, that is a barrier of how often you can see it or how many visits, but we should always be documenting so that we can show that it's clinically appropriate. Movement and grounding. Yes, we are virtual, but like you can encourage them to stand up. I encourage them to have a snack if they need to, or sometimes like, I really have to go to the bathroom. I'm like, okay, then go to the bathroom, right? Like you can take a break when you need to. Oh, I need to go grab my water. With younger kids, I often like to say they love to show me their pets. So they're like, can you see my dog? And they'll bring their dog on the screen or they'll bring their cat, right? Like the good thing about telehealth is you can use their environment and encourage them to bring it into the screen. Let them show you pets' rooms are, their world is the room. Their world is the therapy room. Sometimes they're like, they've been telling me they've been thinking about redecorating their bedroom for the longest time, right? So then they show me like, oh, look at this cool thing I did, right? So it's kind of like, but you want to make sure it's appropriate, right? Like, I don't want them showing me things that would not be appropriate. So you have to set those boundaries too. Multiple modes. I have some clients that they're virtually, they have difficulty, using words. So they might feel more comfortable typing in the chat. Or I've often done pick an emoji that represents what's going on, and they'll pick a little emoji. There's different ways they can express themselves in the virtual setting. There's even been clients that I say to their parent beforehand, can you have paper and marker next to the computer for our session today? I'm going to have them draw something so we can incorporate the art that way. And then co-create together. What do they want to do? Like, don't say today we're going to do X, Y, and Z, right? What would you like to do first? This or that. GIFs, they love GIFs. Oh my God. And they love like memes and all of these things. But you want to give them choice and collaboration so they feel like you don't want them to feel like they're there for a lesson, right? Like a virtual lesson. It's still a therapeutic space. Okay. I am showing you here a poem by Shel Silverstein. So this is an example of an intervention I have used with kids. I'm not going to read you the poem. I'll just read you a few lines. And how many of you are familiar with Shel? Oh, people like, I love Shel Silverstein. Yes. I have this collection from when I was little, and I have some clients that really like poetry. So I'll read just a few lines. You can read here. It's a poem called The What Ifs. Let me just read a few lines. What if I'm dumb in school? What if they close the swimming pool? What if I get beat up? What if there's poison in my cup? What if I start to cry? What if I get sick and die? What if I flunk that test? What if green hair grows on my chest? What if nobody likes me? What if a bolt of lightning strikes me? What if I don't grow taller? And it goes on and on and on. Okay. I've used this in a session. I bring the poem up and I share my screen and we read it together. What do you think I could do as a talking point after we read this together? Like, what ideas, interventions are coming to your mind? What are some what ifs you have? I've asked them to draw their what ifs. What do you think this means? Someone said, oh, it's so funny. One of my clients said, oh, this kid definitely, the person who wrote this poem definitely has anxiety. That's what they said to me, right? And it was a connection point that way. Can you create your own poem? Oh, I like this. This is some CBT work. Someone said propose the opposite. So what if you don't cry? What if you pass the test instead of flunk the test? I love that. Some cognitive restructuring. Have you ever felt like this? I've even had them like do blackout poetry where they black out some of the lines and it can be silly, but like also it can be very meaningful too. So notice here, this is just a words on a screen, but we're using it as the intervention to really do some deep therapeutic work. This is just an example. Another one, I don't have it in the slideshow, but another one I've done is I use Canva a lot with my kids. You can use Google Slides. They're very tech savvy now, is they've created their own avatar. And it's really interesting. It's really good with tweens, like to create their own avatar. And I create my own avatar too. And then we talk about like, what does your avatar have, right? Oh, they have pink hair because I always was wanting to dye my hair pink, but my mom wouldn't let me. Create your own meme, pick a playlist, all of these different things that you can do. These are just examples. Different ages, different strategies. What you do with younger children should definitely look a little bit different than teens. However, always developmental appropriateness. So with younger children, you might have a timer, right? Like we're going to do this for 5 minutes. We're going to do a movement break. Frame it like FaceTime or Skype. Like I need to see your face in it, right? If you have technical issues, go get mom or dad, those types of things. Teens, notice like sometimes they're just like, I don't want to be on that long today. I'm like, okay, well then we're going to pivot and we're going to cut the session a little shorter, right? If you're like, I'm not going to have you just sit here in silence with me. So what are the boundaries? Like teens, even young kids can know if this is appropriate for them or not. And then reassure them that whatever platform you're using is private. I've had some kids like, are you recording this and going to share it with my mom? I'm like, no, I would never record a session without your consent or your parents, your your parents' consent. Closing and call to action, last few minutes here. Like I said, we kind of had to move quickly through this, so I'm sorry. Access matters. Telehealth expands access, but only when paired with really intentional ethics and engagement. Don't just do telehealth for the sake of doing telehealth. Just like in-person sessions, there's good in-person sessions and there's not so good in-person sessions. I actually will argue, and a lot of you work with telehealth, I think more work sometimes has to go into the telehealth session because you can't just grab a board game from your office. So sometimes you have to be really mindful and plan ahead for telehealth, okay? Assess for fit. Don't assume everyone is a good fit. And sometimes it's a trial period. Sometimes they're like, we're going to try, can we try virtual for a little bit? And I'm like, let's do 3 visits together and see and check in from. So something to think about too. And assessing for fit is part of being a clinician, right? Like similarly, we would not take on a client that we don't have the competency or the expertise to work with. Same with if it's not a fit for us, say maybe you're fully virtual and a young person wants to work with you and you've worked with them and it's not a fit, that's okay. We would make a referral to someone that is more appropriate. And then lastly, ground your work in ethics. Privacy, safety, consent always rules everything. And I would say be extra careful with technology because you just want to make sure that you're not exposing a client's medical records, that privacy is always upheld. Telehealth should, biggest takeaway, telehealth should reduce burden and improve access. Okay. Last thing before Bonnie's going to take it over for how you get your certificates is this will be part of the slides updated. It's a little URL. You can't click it here, but it will be in your dashboard. There's a link to a template for telehealth. Do not copy and paste it. It is an example of what it would look like to have a consent form for telehealth. There's a privacy and safety protocol that has a checklist. So like if you are doing a telehealth session with someone, what do you need to know? Like what are the privacy things you need to know? What are the safety protocols that you should think about? And then there's a list too of some games, platforms, activities that you can do with your kids too. So hopefully a little resource guide to take with you, a little toolkit for those of you that are engaging with youth telehealth. Here's the references of where some of the stuff came from. And like I said, this was really like very, very, very fast, packed a ton into an hour. But hopefully there was something that you could take away. I hope you enjoyed this continuing education course from Agents of Change. Want to earn your CE credits for this course? Visit agentsofchangetraining.com or click the link in the description to purchase the course and earn your CE certificate. If you're looking for more CEs, check out our unlimited plan. You get unlimited access to more than 200 ASWB and NBCC approved continuing education courses and more than 20 live events each year for one low annual fee. We're always adding new and exciting courses. Check it out at agentsofchangetraining.com.